Very good morning to all of you. It is rightly said that public health system is a pillar of any country's progress, and more so if it is an efficient one. And that is why, because it is an apt topic, we have Department of Community Medicine from Shri Patil Medical College of BLDE deemed to be university. We have organized a guest lecture today on reforming public health system in India for universal healthcare by our esteemed guest speaker, Dr. K.R. Antony sir, who is an independent monitor, Minister of Health and Family Welfare, Government of India currently. I welcome you, sir. Before we begin, I request Professor and Head of Department of Community Medicine, Dr. M.C. Edvannavar sir, to kindly introduce our guest speaker and welcome.
Thank you, madam. Good morning, all. I, on behalf of our department, with great pleasure, welcome our today's guest speaker, Dr. K.R. Antony, sir. I welcome you, sir. I also welcome our Honorable Vice Chancellor, sir, Registrar, sir, and Dean, Faculty of Medicine and Principal, sir, for this today's lecture. I also welcome all the HODs, faculties, my colleagues, and all undergraduate and postgraduate students who are participating in today's lecture, either by online or offline mode. I welcome one and all for today's lecture. Thank you. Now, I would like to introduce our guest speaker, Dr. K.R. Antony, sir, who is a consultant in public health, child survival, and development. He is currently working as an independent monitor for National Health Mission of Government of India. He was the founding president of Public Health Resource Network India and retired as Director, State Health Resource Center, Chhattisgarh at Raipur, providing technical assistance to the state in implementing health sector reforms and National Rural Health Mission activities. After his graduation in zoology from St. Thomas College, Thrissur, Kerala, he did his undergraduate studies in medicine as well as post-graduation in pediatrics from St. John's Medical College, Bangalore. Thereafter, he specialized in tropical pediatrics in Liverpool School of Tropical Medicine. He worked as a basic doctor among hilly tribals of Wayanad district for 2 years and as a consultant pediatrician in a 150-bedded rural mission hospital in Kerala for 5 years, where he successfully ran a community-based maternal and child health project called Janakshema. He was heading the Department of Community Health and Continuing Medical Education of Catholic Hospital Association of India at Secunderabad from 1989 to 91. As a consultant of UNICEF, he drafted the training modules for doctors and health workers of the entire country on child survival and safe motherhood program for Ministry of Health and Family Welfare India. These modules on newborn care and safe motherhood were for the first time in the country. He served as a state project officer health for UNICEF Orissa in 1992 to 96, for Uttar Pradesh from 1996 to 2002, and was the project officer health and nutrition covering Andhra Pradesh and Karnataka states during 2002 to 2007. From 2008 to 2011, he served as the second director for State Health Resource Center, Raipur. He has wide experience in primary health care, essential medicine, and rational drug use, tribal health, polio eradication, malaria, safe motherhood and neonatal care, pediatric AIDS, breastfeeding promotion, child development, and nutrition. He served as a member of World Health Organization, International Technical and Evaluation Committee on AFP surveillance for polio eradication in India, and as a member of Government of India Common Review Mission under NRHM, and also life member for Indian Academy of Pediatrics, Indian Public Health Association, and Public Health Resource Network of India. He also writes in dailies, The Hindu, The Indian Express, Deccan Herald, Economic, and Political Weekly and British Medical Journal on issues of public health. Under the UN Child Rights Campaign, currently he is also engaged in providing technical support for the goal setting, formulation of strategies and tasks, and monitoring on indicators for making villages and towns of Kerala child friendly. Thank you. I welcome you, sir, once again.
Thank you. Good.
Thank you, sir.
Yeah.
Now, I request our Professor, Department of Community Medicine, Dr. Shailaja Patil, to please give a brief insight of the relevance of this topic. Thank you, Dr. Chandrika, for facilitating, and Professor HOD, Dr. Edvannavar sir, for welcoming.
I just took this small time because I have been associated with Sir since last 12 years, since I was worked as consultant for UNICEF under him, under Hyderabad field office. Apart from the official introduction, what our HOD told, Sir has several other qualities which really make us feel sometimes shameful, because at his age, he is so active. He writes to Hindu every, not, I think not once in at least 15 days or a month. He writes a very good article. You all know that writing in Hindu is a very high quality work. Apart from Hindu, he also is a very vocal public health advocate, because in our UNICEF still which is fundamental to achieve other SDGs. And UHC, we all know SDG 3.8 target is to include financial risk protection, access to quality essential care services to everyone, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So in brief, universal health coverage means access to quality health care by all, and also protecting the people from financial risk from the healthcare system. With this few words, let us have the opportunity to hear from Dr. K.R. Antony sir, who none other than him, who is a better person on this topic. Thank you, sir, and welcome. Sir, have you unmuted, sir?
Yeah, I have unmuted now. Can you hear me?
Yes, sir.
Okay. My apologies. I heard some workers are doing some dismantling work upstairs. So there might be some noise disturbance. I sent message to stop it for 1 hour.
Yes.
But my apologies for that. But I think you can still hear me.
Yes, sir.
Okay. A very good morning to all the postgraduates and friends and practitioners of community health.
Sir, slide show.
And yeah, I can do the slideshow from here.
Okay.
My gratitude to Honorable Vice Chancellor, Dean, faculty, especially HOD Community Health, and to you, Shailaja, for inviting me for this discourse. My topic today, let me start, is about Indian public health system, what we need, how we need to restructure it to ensure universal health care. We are celebrating Asadi Ka Amulya Amurta also we can say, but these type of pictures still haunt our memories and eyes. These are not isolated events. I find that such malnourished children, severe acute malnutrition children, SAM children, all over the country, in maybe numbers are small. And these children who have no privilege to go to school but are under child labor with hard work, and you can guess what the future generation could be. This is where we are thinking of whether we can be instrumental in changing their fate, and we can we ensure a better lives for their better lives and improve their health. So that motivates us, and when we think about that, we apply our public health all learning and strategies towards that. And in between, you hear sometime back the media discussion on the tragedies of infant deaths in Gorakhpur Medical College, and soon the government acted by firing or dismissing the HOD pediatrics. But nobody looked at why there was no lack of oxygen supply. The same thing repeated in Farrukhabad and even in Jharkhand, and in Raipur Medical College also these things repeated. Infants dying due to some managerial issues and lack of proper healthcare. The political parties immediately charged the ruling party, the ruling government, and that is the role of the opposition. TV channel discussions and press coverage are debated. They will limit the discussion to, is it because of the lack of oxygen, lack of energetic medical care? But nobody looks at beyond that. What are the poor resources? Is there a governance issue? And very few are addressing the health system failure in these states. Coronavirus, I'm thankful to two viruses I'm indebted to for my own learning. One is polio virus, because that polio virus took me to the most deprived child in the remotest corner and in such unhygienic conditions, because polio virus requires orophycal transmission. So that gave me access to peep into the most suffering and poor families. Another thing virus taught all of us a lesson is the coronavirus. It exposed the vulnerability and fragility of Indian public health system, because it has been having cumulative neglect for decades in funding and decades in understaffing and infrastructural gaps, and leave alone other technology update. It is needed technology upgradation for long. This resulted in a dismembering of public health system and people bypassing public health system and going to private sector. And it led to the annihilation of public health system in some of the poorer states. But there is a but. It also proved the relevance and essentiality of public health system. The nation needs Indian public health system. It needs it with an immediate upgrade, because it is the only option for the poor. We can pardon others for mistakes. It's part of a learning and growth. Even in a pandemic control, some of the inadequate preparedness before the lockdown and errors in decision-making, whether it was a pan-India lockdown helped or a stage could have been managed with a staged lockdown restricted to epidemiological spread, or the strategies were correct. There may be some mistakes, some advantages. At the hindsight, we can be more wise, and we can pardon those who have committed errors. But refusal to learn from mistakes, that's a tragedy for future. That will never make us grow. What we need is science and latest knowledge should prevail, not politics. Technical advisory bodies should feed into the political decisions and to the governance orders. We have got best of brains in the country. we have got best of brains in the world in this country, and they should concur, not decisions taken by a favored group hatching surprise declaration, even to the ministry officials at times. And even if it is a PMO's office, that should not happen. Now we are talking about public health system which is ailing, which needs a cure, it needs a rehabilitation. Why do we do that? Because we believe as public health professionals, health is a basic human right globally. And even in India, under the constitutional guarantee of right to life, it's an entitlement. It has still not become a justiciable right, means a right that can be ensured by going to a court or litigation. But a welfare nation should own up this responsibility, and it cannot leave that responsibility to a private sector or entrust equipped methods of insurance sector to manage it. You have to manage it. Because private sector is so heterogeneous and scattered in its present availability. And moreover, in this corona pandemic, private sector displayed its lack of standardization, medical anarchy, and uncontrolled exploitative pricing. It was there before, but it became all the more revealing to the pandemic. So much so, the Delhi High Court has to intervene. Karnataka High Court has to intervene for ensuring ICU beds in the private hospitals. Delhi High Court has to intervene to see that oxygen trucks could move across UP and Haryana border to reach Delhi. The government of Kerala was given instruction by Kerala High Court on restricting the costing of the PPE kit and other things. So there was a judicial intervention, and that should not happen. Without a judicial intervention, we need to cure and rehabilitate our health system. When we go further, 3 fundamental questions I want to ask. Whose healthcare are we talking about? Universal healthcare means healthcare for all. But when we say healthcare for all, those who need it more should be given more. And that is the principle of equity. It's not equality. With a special concern for the poor, neglected, and voiceless and marginalized. That's a welfare state's approach and philosophy in ensuring healthcare. Who will do it? I think we can't say that, look around and say, I be hesitant and say, he will do it, she will do it, others will do it. No, in a socialist democratic republic, the whole government has to do it because it's a welfare state, and that government is by the people and for the people. We cannot expect a profit-making private sector to do it. And for this, who will bear the cost? It is the entire citizen of the country. It is the taxpayers of the country give that taxes to the government to run the government. That from that taxes it has to be paid, not by an insurance agency. You pay the insurance agency some fund, and they at their discretion and assessment they will pay. That's all sidetracking. And I said, in a health for all, and to ensure universal health care, we need a reform agenda in the Indian public health system, and that should be pro-poor. And this is what we did it in Chhattisgarh. We had a clear focus of a pro-poor, civil society-driven agenda, taking care of the people's need, and State Health Resource Center championed that cause to a listening government, as a responsible government. At that time, Chief Minister Ajit Jogi and Dynamic Health Secretary Alok Shukla. When we say poor, people-oriented, we have to have clear clarity in what is our mode of function with the people. There are various, working with people, there are different modes. There used to be a missionary mode. UNICEF, James Grant, he believed in ORS that can save millions, and it is scientifically backed up. Breastfeeding can save so much of infant mortality, reduce infant mortality. So you are a believer of a truth, and you are a proclaimer of a truth, and you attract more and more believers. This is a missionary mode. There is a welfare mode. There is a donor beneficiary mode, charity mode. That is, you are a donor and they are beneficiaries. Damien gave leprosy care because he was very charitable, philanthropic, and he, because of his attitude to serve, that he was a donor of service, and there were beneficiaries of poor leprosy patients. You are always a welfare mode in working with people. You give welfare to the people. You are a provider and they are the recipient, and you ensure the channel of your providing services and they receive it systematically. We have got a military approach, mode of function. That is, you set a target and there is you are an operator and the target beneficiaries receive it. To some extent, our family planning program till 1997 had that approach, and that's why we family planning program, a target-oriented military sort of approach, mode of functioning changed to more of a family welfare approach. You had a business model, very star, high quality health service business, and there is a client and you are a service agent, you are a provider of service. This is another mode of working with people. You had a little better development mode in which you are an implementer, but and you are an implementer, but and then there is a partner in it. They are partners. World Bank believes that you are an implementer and partner. But there is most of the health activists, public health activists, believes in working with the people in an empowerment mode. You are an enabler and a facilitator to make people understand their issues, analyze their issues, and make them do how to solve it. And you provide a hand holding, and after some time, they will do it themselves, even if you disappear. So for this, all technocrats, don't think your technology solutions will work wonders in the field without people's strength. People has to be empowered. And that is the philosophy in NRHM in 2005 when it started, the communitization agenda. It starts with a firm conviction that people for whom we work also has got some capacity to think. They understand their problems, they analyze their issues, and they have got their own fine solutions. But it may not be fully correct, it's not technically correct. So you modulate it, and we need to involve them. And that makes the people more empowered, and that is an empowering process towards the human development. Studies have shown an organized communities has the potential to achieve greater results in any change process and in any development. So what do we think in public health to reach communities? What sort of a community we want ultimately? We want to raise their critical consciousness. We want them to know what are the impediments in attaining fullest potential of their growth, physical growth, psychological growth, mental growth, and personality growth, and their development, their capacity to do it, simultaneously enjoying the highest status of health. And health means not only to disease, freedom from disease, in the true WHO definition of full comprehensive health care, and people should be, and this health the community should be demanding it, because they realize it, that it is their right, fundamental right, and they should be involved in managing that health, and then only they become fully development oriented. That is the communitization process in that. Now, globally, in public health, it is an accepted principle now, universal health coverage, UHC. I'll come to that. UHC stands in two modes. I'll come to that in the next slide. So in any way, when we have put sustainable development goal, it has realized that if you want a sustainable development, universal health coverage is required. Should not be any discrimination. Every citizen of a country and this globe should get healthcare in a uniform manner. There should be reduction in poverty, and there should not be any exploitation and social inequities. But India also is striving for all this, is it not? So if in the truest sense, universal health coverage has to be achieved, we just can't say that PPP mode, some private sector will do, and then we get insurance agency. Okay, it's all good strategies or interim strategies. I'm not Ayushman Bharat, PMJY, all have improved at all. But all the PPPs, I just till now, with my wide experience throughout India, except 3 states, Sikkim, Jammu and Kashmir, and Mizoram, the rest of all Indian states I have visited, I'm yet to see one good PPP model working. Maybe I'll give some marks, pass mark to EMRI and 108 ambulance system. That's the only PPP mode I would so far found successful. This universal health coverage, now coming to that, it is improving. It has got 4 dimensions. One is improving the access to people of health. So you have wider coverage of beneficiaries, the beneficiaries who are hitherto not attended into the remote areas and in the remote rural areas, in the dens of forest, isolated communities in the cut-off islands, flood-prone areas. So, and not only that, you improve the access by increasing the frequency of services. Once in a while, mobile clinic changed to once a month regular clinic, then twice a month regular clinic, twice a week immunization services. All these are improving access. Now you all know that the improving range of service, expanding the package. You started with the primary health care with the treatment of minor illnesses, family planning services, immunization, little bit of malaria control. Now from there you are increasing the package of services to non-communicable diseases, availability of medicine and diagnosis and treatment for diabetes, to cardiac care, sustained treatment for hypertension. No, even to cochlear implant and cardiac valve replacement, everything. Some states have improved the health coverage so much according to the. There are pooled resources even for the worst of cancer cases, even to ECMO. There are pool funding taking place. It's not part of the government service, but that's the way, the range of services, the spectrum that can be expanded. You are improving the quality of service. It's not sarkari dawa, you don't know the standards. No, high quality tested drugs under the Jan Aushadhi and all, and technological advancement. Even you get MRI, CT scan, everything, even in the government hospital. All this, the 4th dimension is ultimately the client is satisfied, client is getting their due share, and their participation in seeing the quality of service, their empowerment in monitoring things. So this is what is expected in universal health coverage. And there is the 4 dimensions I'm talking here about this, improving the reach and access, the range of services at an affordable cost or minimum cost, with an assured quality, and overall this universal healthcare satisfying the client. I told you about the UHC deceptively stand for 2. One is a coverage, but there is another called care, universal health care. What's the difference? Care is a limited package of services which primarily dished out by the health department. But universal health care, we are looking at social determinants, like safe water, like better sanitation coverage, nutrition, food security at family level, ensuring primary education, ensuring minimum livelihood and wages, so that they can purchase their food and they need not be starving. Poverty aversion, and poverty makes social disability of a person. It's his image and his personality is such a submissive, meek person. He cannot stand up and say and assert his right. So gender equity and social equity, so they have the voiceless are heard. These all includes in universal healthcare. That UHC is what we should be as true disciples of concept of community development and also practitioners of public health. We should try to assimilate. Then it is no more, if it is a universal health care, not universal health coverage, that means health ministry from UHC of universal health coverage has to expand and work seriously with allied sectors and need to build up its capacity for intersector coordination and to have that enabling role. And it is a mutual thing, and a responsible government should more facilitate universal health care. Now, coming to the cost of healthcare, UHC, whether it is universal health care or coverage, or it needs a financing system. You can't expect citizens to buy from their pocket, because any health hardship may not be an individual's faulty actions, a result of that. There are social factors. There are so many other determinants. So if somebody has got a misfortune, a welfare state with responsible citizenship and with the governance system which is taking care of all the citizens, it should say it is a calamity occurred to the whole thing. So the pinch of that should be felt by every healthy people also, because he's an unfortunate fellow citizen. So that is the what you call it, the sublime approach of you care for your brethren, you care for your fellow citizen. So I'm healthy, I'm lucky, so I'm happy to spend 10 rupees more so that an unfortunate victim and millions of people contributing. And that is the pity of the government. Health expenditure government is very low, but the government should take care of that. That's the principle of national health system in UK. Health expenditure government is very low. Thereby, if the government doesn't spend for this, somebody else has to do it. The suffering, miserable person has to spend it from his pocket, and his pockets are not very deep. So it's out of pocket expenditure breaks him, and he goes into indebtedness, and a costing of financial healthcare is fell upon him. He has to pawn his jewelry, he has pawn his land, house, everything, just to see that he live. That should not happen. In a democratic country, financing healthcare must be from a whole resource, from every citizen, tax fund. It cannot be left to the vagaries of market forces and how insurance sector does its guesswork, and because insurance sector is poorly enrolled, whether it's mandatory or voluntary, and poorly reimbursed. I'll come to that next after some few slides. See, these are all some old statistics, not very up to date, but per capita health expenditure varies in states. UP is only 790 some time ago when we had estimated, and whereas national level is 1538 rupees. So double the amount. So if you invest, a state invests so less, low investment in business cannot have big turnover and good product. Poor spending is poor returns. That is pure business model. Not this year, last year, we expected an allocation of about 80,000 crore for health, so that at least health expenditure will improve. But of this chunk, then 55 to 60,000 crore can be allocated to National Health Mission. But did not happen. We had some 30,000 crore, and then there was an explanation, water and sanitation, there is a 50,000 crore there, that will improve health outcomes, sure. But that is not enough. Globally, the proportion of GDP for health expenditure is around 6%. We in India are asking at least 3% of GDP as a priority investment in health sector. And then you can slowly can make it an incremental increase. What's happening in the actual scenario, we hit a rock bottom of 1.15% of GDP budget in 2015-16. Thereafter, it is 1.18 and then 1.3 in 18-19. That almost remains in 1920, 2021. It is even last year, it is not much increased. So when you always say the thing, I am talking about how we are not spending. I'll come to the unspending, under expenditure and capacity to spend later. Let us take the fund requirement for the entire, if you put an ideal district of 2 million population, that is 20 lakh population, it's a larger size, not some other districts are political reasons are very small, and that's not the case I'm saying. An average district of 20 lakh population, you need about 844 doctors and specialists in CHCs and district hospitals. You need about 2,000 and odd nurses and midwives. You need about 1,300 pharmacists minimum to operate in the peripheral curative center. You need 19 dentists, about 220 support staff. Totally about 6,500 health staff. It will incur a cost according to the salary is prevailing, about 17 crores per month and 228 crore per year for a district. And we have got 733 districts, but many of them are small. Say on an average 20 million, about 600 districts, it comes to 1.37 lakh crore. So staffing adequate human resource itself is 1% of the GDP. You existing 1.3% of GDP plus this 1% of fully functional human resource, it's about again 2.3 only. We are not still reaching 3% of GDP. So there is a scope of spending if we find the money. And where do we spend the money is what we should think twice, and the government should think twice. What happens is when health expenditure is low, this is again 2011 Lancet article, Balarajan and all have said about wide interstate variation in 2005. Bihar is 93, whereas Himachal Pradesh, better off state, is 630. Anyhow, even in Kerala, there was a Kerala Science and Literature Society, KSSP study. Out of pocket expenditure per person increase from 60 times over the last 25 years, from rupees 88 in 1984 to 5,000, nearly 6,000 in 2011. It's mainly because of this new price rise of medicines as well as diagnostics, CT, MRI and all. So when out-of-pocket expenditure crosses more than 20% of their income, it can lead to impoverishment. It's a WHO, it's a common sense. WHO doesn't have to say that. But India's out-of-pocket expenditure for years, 2010 onwards, it hasn't changed. It's in fact, even latest is about 62% or that, I stand corrected exact amount, around, it hasn't come down. It hasn't come down to 50% even. So when such a out-of-pocket expenditure burden is there, the poor man suffers. We are claiming that in the BRICS, we are on par with Brazil, Mexico, and South Africa on the middle income country status, and we are happy. But our GDP has grown and moved to a middle income country at the expansion and improvement in hardly 5% of the population. The gap between the rich and poor in this country is still widening. Even the post-pandemic, Chinese billionaires have increased. America's billionaires, number of billionaires have increased, even in India. So when even in a pandemic and with the impact on the economy on the lockdown, the billionaires are increasing. There is a huge poverty burden of 22% of the world population and still in India. India is, it's improving many other fronts, but our poverty load is still there. So challenging, and on that poverty load, there is a double burden of not only the uncontrolled communicable diseases, still TB, malaria, and non-communicable diseases like diabetes and hypertension. India is increasing. So And the NSSO estimates 20% of the illness, everybody, the poor, where do they go? They don't go anywhere. They just manage, push the days. If natural healing takes place, it's okay. They are still in the field, they go for work. But unless it is very debilitating, they will go to the nearest RMP, spend a lot of money. And there is a delay in availing treatment to locally available, cheaper, rural medical practitioners or quacks. So that has come. You say that insurance coverage is the savior. The planning Niti Aayog and all still believe that to push your insurance coverage. NFHS 5 data shows we have reached up to about 41% of households with at least one member covered by health insurance. And it varies between urban and rural, 38 to rural is slightly better, 42%. But in the state variation, you see, it varies from, even in Kerala, it is only 51%. Tamil Nadu, 66. AP is better. AP is better. Chhattisgarh is 71. And Rajasthan, phenomenally 87, 88% coverage. But the rest of the big states like UP, 15, 16%, 15% Bihar, and Maharashtra, the very supposed to be industrially developed Maharashtra is 20% coverage only. Even the rich Punjab has got only 25%. Haryana is only 25%. So there was the Zoom meeting the other day, and many experts were saying the penetration of insurance sector hasn't been. Penetration is low, and the settlement ratio, claim settlement CSR is low. You raise flimsy excuses for denying the claim, and there is an unmonitored or uncontrolled health system institutions which make more profit out of the insurance as a provider. So the regulators are not strong enough in having an efficient health system insurance like in Canada or Germany or something. We have miles to go. Under this dismal situation, we are given the responsibility of carrying this very delicate, very fragile human being in our hands. We are the thumbs and palms of the public health system. You are the future. You are holding. You have to speak for them. And we, like this elder tribal boy taking care of two other siblings, equally malnourished. We are supposed to take care of them. And then we need an out-of-box thinking. And such thinking has come historically. 2005, NRHM came with a vision. It's a revolutionary vision. It believed in decentralization. Decentralized from national level to the state and state to the district, and district as a good planning unit, composite planning unit. And for this district health management system, we need a participatory bottom-up planning. A very visionary health secretary, I had the privilege to interact with J.C. Pant in 1997, came out with liberating Indian health system from the target approach to a target-free approach. It was ridiculed by many, but then it started with the process of community need assessment in the PRA techniques. And health ministry, though the rural development ministry was scaling it up with the UNICEF assistance, our health sector used all those techniques of participatory rural appraisal and learning. We call it PLA, participatory learning and action. With action, we had a participatory bottom-up community need assessment and scheduling services and ensuring. So this has happened with the, and this in 1997, after 8 years, in 2005, it got formalized in NRHM. NRHM ensured in quality of services and client satisfaction. It believed in intersector convergence, and it set time-bound goals and report, and also transparent reporting to the public and civil society on the progress made. And it's all because of improving access to rural people, especially the poor and vulnerable, at an affordable, accountable, and effective primary health care. NRHM had a paradigm shift. You have a Pakka Sarkari approach of mistrust everything, distrust, and distrust to more of a trust. inflexibility and audit objection to more flexible, innovative planning, centralized to decentralized action. And we provided that believe without no big talk works without adequate funds and clear marked functionaries for clear functions, and then build up their capacities at all levels. These paradigm shift resulted in many things. Now we need when we talk about increased budget allocation, increased allocation for health services and universal health care, we need, they always say, you don't have proved your efficiency spending. So that needs an efficient health system at district level. And it's a crucial thing is district health spending capacity. So center must assist technically in all states, improving public health system at state level and at district level. We need a two-pronged. You give funds with a lot of trust, freedom to express, freedom to innovate and do. Make mistakes, but timely, quickly correct it. So that you give on the one side, and that you believe and try to skill up their management efficiency. And we need fund swallowing, as it happened in UP, you know, the scandal of 400 crores siphoned off, and two CMHOs had to commit suicide to cover up for someone else. These are all, I mean, I know this speech is recorded, but these are all which came in papers. I'm not giving you gossip. It is so such things should not happen. It should be a transparency in transaction, and I'll come to that transparency in transaction, how we plug that. We need national level management experts who are not advisors by political appointment. We don't want many commissionerate and thing which are political appointments. We want qualified real management experts. You need a national cadre of public health, like IAS. Why can't be IMS, Indian Medical Service, be constituted? It's high time we think about it. Niti Aayog is thinking, I am happy about it. And Niti Aayog has exhorted after a few consultations to have a public health cadre. Building is a must. I am very happy that Karnataka also finished a few workshops, and there is some emergence of consensus is building. That I am very happy about it, and should happen more. Challenge of how do we fund absorptive capacities in the right way? I'll tell you two clear examples. We need a professional project management. When NHM came, we did not believe and trust entire responsibility to the Director of Family Welfare and Director of Health Service to run the show, because they've got their own mundane activities and budget allocation, state fund and all. So we created a state program management unit, program management in every state. NHM created, NRHM created. We found a lot of human resource vacancies. We hired a lot of contractual consultants, technical hand, lot of obstetricians, anesthetists, pediatricians. We hired them to make sure FREs are operationalized. We hired management consultants, MBA graduates. We hired every district hospital to have a first time, every district hospital in Chhattisgarh. I'm happy to recruit 17 hospital management qualified professionals and place them. They were young graduates bubbling with enthusiasm to improve their. A clinician medical superintendent may not get all the time. So like that, it built up in all the states, and about 275,000 contractual workers are there. They are essential to run the project activity, and they are adding value to the program implementation. We have reaped the benefit out of it. There is documented. And that was the cornerstone in transforming the mundane state health services as a mission mode instead of departmental activities. Every SPME, you find a lot of young teaming youngsters with enthusiasm. Sir, I will do this weekend. This can be solved that way. So encouraging as a team mode, the mission directors in each state work hard. That quality improvement led to client satisfaction and increased utilization of services by public health system. There are PHCs which had in Bihar and some parts of Orissa, Sonpur, I remember all that, cow dungs in such health institution. Many people have in it. I asked just a casual story. I asked for, stopped on the way to Faizabad on the way from Lucknow. I asked where is health center, स्वास्थ्य केंद्र. So आगे 2 किलोमीटर के बाद ये हमेशा ताला बंद एक बिल्डिंग है, वो है पीला वाला, वो है हमेशा ताला बंद. So that is the impression the public have. Such health centers have such a new branding and logo and services. People say हमारे hospital. So if NRHM could make that difference in the, if they are inevitable to run the health program, make these contractual staff permanent and pay them and consume the funds increase and increase the allocation of funds, and your GDP proportion of allocation, if with a useful manner, will increase. Another huge chunk that made a difference in the image of the public health system in the country, from Kashmir to Kanyakumari, from the China border of Upper Subansiri in Arunachal Pradesh, this Asha Sahib. These are the young recruits who have a licensing between the community and the health system. The last peripheral outpost of Indian public health system was an ANM, and every task was dumped on her, poor thing, to some partially little bit to the male health worker. But now there is a activists linking them, but there is again a dumping syndrome has happened. These are dumped with every task, but they have proved their mettle during the pandemic. About 9 lakh women are part-time voluntary workers. Why do we call that voluntary? It's such a hypocritic word. It's a highly exploitative anti-labor arrangement to overcome requirements under the prevailing labor laws. It is, these Ashas, 9 lakh Ashas, was the backbone of entire surveillance activity in the community, contact tracing, getting suspect tested, quarantine of family members, isolation of clinically asymptomatic positives, reverse quarantine of vulnerable and elderly people. During the pandemic, Kerala, at least, I am immensely impressed by their work here in Orissa and in Andhra. These are places where these Ashas made a difference. And the mother of all Ashas, the Mithanins in Chhattisgarh, the Mithanins were the only source of any trunk during the lockdown when many of the institutions were locked. They had their Mithanin ka Thaili or the Jola. They had some medicine, some paracetamol, some medicine for them with cotrimazole and other amoxicillin and all of that. So if they are inevitable as an intermediary between health officials and the community, accept them. Your team member, pay them, charge it to the NHM allocation, and you, let it improve the proportionate allocation of GDP to the health system. And the capacity to train these illiterate Ashas is enormous. We have trained in Chhattisgarh the Mithanins to give medicines to take blood slides, to do Nischay kit, to detect pregnancy. They are doing, even trained in a postgraduate in pediatrics does in a proper way of mucus sucker in a newborn with secretions, in giving use of an ambo bag. They were ventilation and handling and neonatal asphyxia in case 30% of the home deliveries, there is no one, an Asha Mithanin is taken care of. I visited Bilaspur JSS Hospital in Ganiyari near Bilaspur. This is a 10th class tribal girl in one of the health centers, picked up in Ganiyari Hospital team. There is a cardiologist, because it's all a team of doctors from all India Institute have landed in this rural area, forest department sheds, and converted to OT theaters and everything. And I found this 10th class girl doing echocardiogram. She's trained so well by a cardiologist in AIMS. So what I'm trying to say, there is a scope of improving our health system functionaries at grassroots level and still deliver services. So my net message here is increase the budgetary allocation of allied sectors also. Now, good that water and sanitation has a 50,000 crore increase. Invest more in the determinants like nutrition, ICDS, rural water supply, sanitation, Swachhata Abhiyan, and that will and argue for it. The health department should take it as their needs. These allied sectors are given improved allocation so that the ruling government will show its, it can fly its flag very high with pride that India is progressive. If these scenarios of these pots of water being carried on the past like drought-prone areas, we can't make universal health care or health coverage meaningful. This is, I had an old picture where there is a three-pot figure. There is a pot of water on top, and there is a side pot of a 2-year-old or 1.5-year-old child, which is cannot be left at home while she's going for the water. And there is a front pot, which is bulging because she's already 34 weeks pregnancy to deliver the next baby. And this is the typical three-pot figure of a woman carrying one pot on the head, the other pot on the side arms, and then there is a one pot inside. So you can't have a meaningful universal healthcare under these circumstances. These are also not an old stories, but in some parts of remote areas, desert areas, struggle for water can come up to this level of a photographic image. Even more deplorable is though these children are playing, because the school uniforms they are wearing, they had been to school, but now they are out. So children out of school is a tragedy that is going to happen in the villages of India, even after Azadi Amrit Mahotsav. When I went for polio monitoring, I saw this girl this photograph is in Karnataka. I think in Gulbarga, between Gulbarga and Raichur, but I've seen many photographs, not a single girl, rows of girls with confidence on the blue cycle, birdie, they call it, ladybird or something. They climb on and they come with the books and they go through. And I've seen it in Andhra Pradesh. They're all proud. Amara Chandrababu Naidu, Chief Minister, gave this cycle. All 8th class pass girls on cycle. If a girl is in school beyond 8th class, she's in school uniform and confident and they're happy. It's a sign of diminishing infant mortality in another 6 or 7 years. When she reaches 20 or 21, gets married, the infant mortality will be down. Maternal mortality will not be allowed to take place because she will demand I should be taken to hospital. She will control the alcoholism of her husband or post-wedding. She will take a better better initiative to conserve her savings so that it is spent on good cause, not on wastage. So that is a sign of reduction in infant mortality, under 5 mortality, and improved social living in the families and improved nutrition practice at home. So girls have to be in school. So the current, we would speak so much of theory on universal healthcare. The current attitude and mode, and I have no hesitation even in blaming World Bank on this, the PPP mode, private sector to salvage. Already they are 67% contribution in health services. So if it is, I don't mind private sector people going for it, but if it is uncontrolled and profit oriented, and they have the same inefficiency, they have the same quality compromise on choosing the drugs, what investigation methods, and exploitation of gullible, pushing them to indebtedness, and there is absolute lack of transparency, not even provide a bill, that's what happened in lockdown period. One organization called Sati in Pune had to go and fight a case against 5 cases they have won, and made this 5-star hospital to refund the money on exploitative way of billing and very so do we expect private sector to take interest in disease prevention and health promotion? Recently there was a big workshop on role of private sector in primary healthcare. Private sector will be that much interested, and what are you trying to do? They are only looking for profits in any of the private healthcare primary care services. Even in Ayushman Bharat, whether they are thinking whether they can have make better profit with that. You can't. So coming to more, one of the blames made by Government of India on states is that you don't understand, we don't get the utilization certificate. I found one of the reason, the main reason is annual settling of accounts. Make state planning cycle for 5 years, not annual. Some of the UNICEF, many of the global agencies are doing 5-year planning cycle or 4-year cycle, depending on the funds are short. You make a planning cycle for 5 years. Then why otherwise the whole process of reworking on annual planning and budgeting from December, this is what happens typically in any state. From December onwards, submit a draft plan in January. It's a laborious and time. I think we had to sit up till 3 o'clock in the morning and all, and their team and finish that so to meet the deadline and put many days, not one day, and then again come to office at 10 o'clock and start working. And it is all, but the budget allocation goes, these plans go for review, presentation in Delhi, and then cutting, and finally after March 31st, budget allocations are done. But whole administrative machinery is busy, anything to do because they are closing annual account in March, and that first tranche of funds reached by June. It is slightly improved recently. I give credit with more financial monitoring systems have come in NHF. I don't deny that, but it used to be like this. And that too will be a partial first tranche. And that won't be enough to give big expenditure like buildings and all to PWD contract and things like that. So small routine things and pending salaries will be paid and all. So actual implementation is 6 to 8, some from September, August to about December. So you don't get the implementation window very large. So instead of that, you make planning will be undertaken once in 5 years. You have broad strategy to achieve general objectives and goals. Phasing of annual financial allocation of project cycle is clearly written there. And what is the task? You quantify the outputs and results each quarter-wise and year-wise. And what is the expenditure for that? It should be a regular machinery which should be giving these funds periodically. And simultaneously, you collect the utilization certificate for whichever funds are spent. So it should be a continuing process. There is not a final closure. This is an age-old British system. March 31st should be settling. All accounts should be settled on that day and then restart on April 1st. Funds must be earmarked from the beginning of the accounting year for fixed expenditures like salaries of the staff. They should not be penalized for the year fund as income. Electricity. The salaries of staff mean both permanent as well as contractual. Electricity, water supply, waste disposal, telephone, communication, which can wait. Which of these can wait? No. Consumables which has to get, regular supplies like oxygen, essential medicine, nothing can wait. So we have to have these assured expenditure funds coming in a regular fashion. So this is one important thing that we need. And I talked about transparency. I had very good experience in Chhattisgarh because Chhattisgarh was competing with Goa and Chandigarh and Himachal in application of IT. So to eliminate, and that's the time 2-3 directors police was after it, a lot of allegation on corruption and all this happening. And at the time I was given a task of 950 NRHM posts like a clinical psychologist, counselors, lab technicians, all were not appointed for the last 2 years because of these various court cases and all that. So this responsibility, we hired a technical agency. We completely made it IT enabled and everything was clear. There is clear about the application, who are there, category wise, SC, ST, OBC wise, who are the applicants, what is the quota, what is each candidate, what is the theory mark, practical mark, and or skill test mark, and the interview mark. And it's all uploaded, nobody can do it. So it is needed, IT applications needed web-based for a fair governance and transparency to the public. It strikes at the root of the corruption. Whether it is advertisement of vacant posts or recruitment, test selection interview, transfer of health staff, award of contracts to civil works, and even when was the bills, checks are paid after completion of the work? Was any dust delay or somebody asking for extra cut for releasing of the check? All these are, when it is IT enabled, it's transparent, it can be done. Okay, I finish on the transparency and IT enabled. Another thing what we need is, we have got, because India is a vast country, Hamara Bharat Desh, Sare Jahan se, Acha, because of these people like this, many, this is an a girl who I found in Tamia block of Madhya Pradesh when I went for a CRM monitoring. She climbs down a big, huge, catered like pit. It's like as a meteorite has struck Earth some years, thousands of years ago, and there is a settlement and there is a forest and a village there. She walks down with her vaccine carriers 2 hours, and climbing up is 3 hours, 5 hours to reach the children of that Patal hamlet, which is in thing. Who sees them? Who recognizes them? Nobody. So I put up this picture, and Sujata Rao was so impressed by this girl's picture when she was the health secretary in Delhi in the Vignan Bhavan, and she really think, and that's the time when we started in this all these award and Kaya quality, and then staff who are performing well to be awarded Independence Day, Republic Day, and all. So we need that. Doctors, no, doctors, even in her PhD doctor elopes. He comes only hardly 2 days in the PhD a week. The rest of the time he is in private practice 25 kilometers away in the block headquarters in Tamia. But this place, she is not impressing that medical officer. And that eloping, fellow who is disappearing, he is not punished. He is, but a worker who is working hard is not encouraged. So, and some of them are stuck. So lack of fair and non-discriminatory transfer and promotion policy is not there. Transfer and promotion has become a money-making industry in many states. And they are all in the hands of health ministers who are people's leaders, elected votes. But sorry to say, they make the money out of it. It's a naked truth, but people don't want to talk about it. How to prevent this? So for this, also Chhattisgarh, we did a model of, we categorize all PHCs into most difficult and less difficult and best. So we categorize the PHCs into these type of 3 zones, and most difficult zones, we post the beginners who are recruited in the initial stages for 5 or 7 years. And then it should be computer locked system, which hasn't taken place in Chhattisgarh. Even then there was interferences. But then you come to the second stage of sub-district and sub-divisional hospitals and CHCs, FRUs, and ultimately in district hospital. But the staff vacancy structure is that all that who are deployed in PHC as assistant medical officers do not get a chance to become the district hospital staff because posts are. So automatically there is an attrition as you move higher up. So you prescribe the minimum number of circle 1, circle 2, 5 years, 7 to 10 years. And then there is no chance the candidate has got an option to, wherever he in the periphery has found a good practice, he is popular, let him give it. He will resign and start a private hospital or a clinic there, and he moves out. And wherever you have clicked well, you give an option, but everything is transparent and clear. And we have to, in the posting, we should not get through minister's influence an MBBS fellow to fill up the specialist leave vacancy and get stuck to a district hospital or a sub-divisional hospital, an area hospital in Andhra. No specialist on same way. On the reverse side of the coin is an MD psychiatrist, psychiatry person should not be posted in a PHC alone. Not that the rural people don't need a psychiatrist, but we can't afford them. There is a district level psychiatrist posts are vacant. And why do you put it? Then the Maharashtra junior doctors went on a strike based on my article in Hindu on this discriminatory practices and specialists getting stuck in the periphery. We did a similar thing in Chhattisgarh. We found 37 postgraduates rotting in PHCs. We pooled all of them. There were then in the next PHC recruitment, out of 125, there were about 60 or odd were specialists. We decided, and the current mission director Vikas Shri, I was the health secretary then, we did, I think, that they will never be posted in PHC, but they will be posted maybe with the PH assistant medical officer, great salary, but they will be working as consultant, qualified specialist in FRUs and CHCs. The other thing, phenomenal thing, what people want is Hamesha Taliban Sarkari office. Instead of that, they want availability of drugs and diagnostics. Though health is a state, so we need drugs as per the need and the caseload. We need resources like a national government should have been little, what you call, very realistic in the allocation of. We can't have same malaria funds allotted to all districts in a state, even for Chhattisgarh. When 45 blocks of Bastar has got the 80% workload malaria cases of the state. So you have to have prioritized allocation of a differential allocation of where the disease load is, which is epidemiologically very sound and scientific, whether it is TB, malaria, or then, and then you have make sure where there is a need, drugs are available. Where there is a need for diagnostic, drugs are put. You don't allot the same diagnostic machine or 300 mA X-ray machine to all places where there is not even a radiologist or a X-ray technician appointed there. Then you install there. Whereas the other place you have got staff there but don't have the machine. That should be. I'll quickly run through in 10 minutes. I want to finish. 50, we did this, the status of availability and access, pricing of essential medicine. The first time in the country in Chhattisgarh, we did a 50 essential medicine list as per the WHO methodology. And we found only availability of 50 essential medicine in the in the health institutions we assessed, only 17% had that. And the markup price for retailers pricing is ex-factory price, 35% is by the distributors and agent, and ex-factory all the state level dealers and district level dealers. But 15% is supposed to be the markup price for the retailer at pharmacy level. You know what was the markup there? 376% increase of some medicines. So for the answer to that is bulk procurement of generic essential medicine. And we have a beautiful model of TNMSC, Tamil Nadu Medical Service Corporation. And I was spearheading this replication of TMSC. Luckily, 2 states that have come immediately to emulate Tamil Nadu model is Karnataka for the first time, and then second Kerala, and then 6 states like Bihar, Chhattisgarh, Kerala, Rajasthan came. And Rajasthan is a place where a very dynamic collector made the Jan Aushadhi as a viable model. So this availability of drug is more important, and Tamil Nadu model of procurement and supply of medicine, equipment, and consumer must be enforced in all states with poor governance success failures. There is a centralized pool procurement, which is which is in pipeline over the months, and it will be in different parts of the state. It is not state headquarters, every medicine coming. You should go to each district from the manufacturer itself, and then so that in the pipeline is not any flow. Pipeline flow must be without any hindrance. That is one. Then insurance-based purchase, we can have an Ayushman Bharat purchase of secondary and tertiary care from private sector when the government system does not. But it cannot be forever. It cannot continue with, if it is continuing, it should be with stringent oversight and guard against misuse and exploitation. Outsourcing and rate contract-based purchase of diagnostics from private sector should give way for an in-house provision slowly. But It should not be, because that should not be a money-making racket. And it is possible. And that is what happened in health and wellness centers. This comprehensive primary health care, which includes a treatment, diagnosis and treatment of non-communicable diseases and health promotion activities. This is what in health and wellness centers. I have very deep down at the field level, I have assessed Chindwara district in Madhya Pradesh as a government of India assessor. I've been to Bishnupur district of Manipur, and I found a trained nurse or a pharmacist or a sector supervisor acting as a community health officer, or pharmacist, running almost like a mini doctor. And I visited them. You know, the community leaders, yeah, Mara hospital. Yeah, that word, the community leaders saying, yeah, Amara hospital. Yeah, Amara chota doctor, mini doctor. Amara mini doctor. Hai. And what they found is there is an availability of 24/7 hours mini hospital. There is one of the staff staying there, and there is a medical consultation. There is a diabetes and all uristates and diagnostic is taking place, and there is a dispensation of medicine, and there's provide first aid in an emergency. So it is a hospital. It is a hospital, and that is part of the. Many public health people thought community medicine means nothing to do with medicine. No, that is changed. So we need a comprehensive primary health care, and that is one viable model existing is health and wellness center under National Health Mission. I hope it is not all perfect in every state, but it is showing a change in trend. Now coming to the communitization. Community should own, and it moved me when some village sarpanch and all said, "Hamara hospital hai, hamara mini doctor hai," sort of the thing. How we can make the community's own? The only salvation to public health system for its inefficiency, for its whatever little element of corruption and all, is people's watch, a community eye. For rejuvenation of a weakened and corrupt public health system, we need a strong ownership by public, a user involvement. Rogi Kalyan Samadhis and hospital management committees were designed for that. But it should be a community watchdog rather than just one MLA or MP. The user groups and community watchdog and facilitate social audit. It has happened in northern Karnataka and in some taluka of so there was a beautiful community monitoring project, and that's why I'm referring to that in Raichur and Gulbarga, and there are some NGOs also involved in the Jan Sunwai and all came up, but it should not be annual one event of Jan Sunwai, but it should be an ongoing process of communities. Rohi Kalyan Samadhi, it has got huge potential to be a vibrant platform for convergence of different line departments, providing better health to the poor, and getting public health institution getting a facelift, lift. Laboratory and diagnostic service, resolving staff vacancy by temporary contractual appointment. And it's also generated discussions locally among the community leaders beyond the hospital about what should be done. So it was a positive experience. But the negative side is most of the places, some of these are on paper, not much functional. Many places, I won't say most. There is not a true grievance redressal or social audit taking place. There are some project mode approach, but should be internalized, it should be regular. Agenda of meetings of our case is mostly around the infrastructure building, and the collector has to preside and get the approval. So it is more to get your signature. And some RKs started levying user fees has led to the marginalization of the poor, but then it is stopped now. In some places, they have their own fund generation, like in Madhya Pradesh and not many places, taluka hospitals level thing or CHEs, the compound have peripheral buildings constructed towards outside, and they're given on rental to shops, front shop. That income comes to the CHC or something. So there are models like that. And people need to be, for repairing these Ragi Kalyan Samadhis, people need to be aware and functions of the RKs, membership is not by nomination by the concerned doctor or medical superintendent or CMO, because then they are obliged to them. Then becomes I'm a sati or thing, and you are a mute spectator there to sign and support whatever CMO says because he appointed me and given me the position. That should not be there. He should be a very scrupulous monitor and raising voice if things are going against the interest of the people. Instill motivation, and we need to instill a lot of motivation and develop capacities of our case members how to assess things. We don't assess, is it a good quality construction, is it a good quality plumbing done, what should be done, what is the implication of a CT versus a MRI, which one is more needed. All these things we need some technical knowledge imparted to them also to monitor that. And that professional assessment of existing level and gap analysis for that hospital improvement for a future has to be more professional. So the Rogi Kalyan, some of these can be improved upon like this too, and they become good evaluators. Now, when people are involved, things can be so different for any state. And typical example is the pandemic control in Kerala. We already had about 26,000 of ASHA workers, and we had about 33,000 Anganwadi workers. But apart from that, we had 45.4 lakhs of neighborhood women entrepreneurs at grassroots level in 2,90,000 neighborhood groups. And that includes even 48 transgender groups also. So that Kudumbashree members were a huge strength for Kerala to handle the pandemic at grassroots level. There are Panchayat members are oriented through KILA, where I am associated in a child-friendly governance for children and women. There are 21,000 ward members and about 978 village GPs and municipal corporations. They're all oriented. And recently they are trained to go the extreme parties, or what you call the most vulnerable, identify them. And there is a huge survey that has taken place, and so that nobody in Kerala should go hungry and starving in the night, and community kitchens and all those things. There were 45,000 registered volunteers from IT sector, college students, everything. And they were manning the kiosk, and they were and you should see interstate borders, how they were regulating. I was so thrilled. I wish the whole country had this type of community mobilization to help the hands of the health department. And that makes public health activism as not a dream, but a reality, empowering the health system functionaries to function better and leads to better client satisfaction. We need, with the pandemic background, we need telemedicine as a regular modality for health promotion, follow-up of NCTs, and partial counseling in mental illness, palliative treatment. We need good institutions of repute in virology, vaccine production. We closed down many public health. Ambumani Ramdas's time, it's a wrong decision to close many of the public health vaccine producing centers. Of course, Serum Institute and Bharat Biotech and all these pharmaceutical, India is the pharmaceutical capital of the world. There is a thing, but that doesn't mean that we have to have a backup of when in an emergency to have produced vaccine centers. We need a state to have communicable disease control centers like National Institute of Communicable Diseases. We need more allocation to local self-governments for LSDs in health services planning the way they want it. It's not health department budget. It is local government LGS, LSG fund, but we have to take. We need a strict control of the private sector. Clinical Establishment Act has to have a regulatory function and should be it must have more teeth to bite. We realize that liquid medical oxygen generation plants in every district hospital. Now there are 733 districts. We have got about 300 medical colleges around, and some of the medical colleges in the same district 4 or 5. So there are a number of districts which doesn't have a medical college for tertiary care college. we need to have plan every district hospital to have a specialist in every specialty, and with their own ancillary units like dialysis unit for nephrologists. There is a burns, and there is a coronary cardiac unit. There should be all these things, rehabilitation and rehabilitative medicine and physical medicine, like post paralysis. So every district hospital should be competent enough to function like a medical college with regard to service. Medical college, the only thing is additional teaching takes place and training of young doctors takes place. But district hospital should be like a mini medical college with regard to tertiary care. It is in a district, that is the only tertiary care apex body that should be full-fledged, and it should not have any lack in it. Like we must have an ICU beds, minimum ventilator beds of 5, like that. Two more slides. The pandemic has shown wealthy cities may not be the healthy cities. It's all in all urban settings. It has been proved. And the urban poor condition is miserable. You talk about domiciliary care and home isolation. Where is to isolate? Into 8 into 6 cubicle in which the cooking, saying, where is the point? How can we isolate that? So you need community isolation centers in such places. And there is not even provision of basic service of water, sanitation, and clean night shelter or for these temporary settings. I found in Manipur, I found every village to have a community center which has got a raised platform, and it is used for during cyclone, floods, earthquakes, and recent pandemic. It's useful for relocation and relief camps, isolation and quarantine. It can be done for community meetings and social events and wedding. So if just like an Anganwadi center in every village, if every Gram Panchayat to have a multi-purpose community centers which can take care of disasters and many adverse events in the community for temporary provision of services is an important tool that can look. I wanted to, before I stop with the drumming for a feature, I just went through the rural health statistics. We have primary health centers numbers are coming down in some states. I don't know, maybe it is falsely classified as primary health centers. Goa had a substantial reduction. Jammu Kashmir had, even in Karnataka, there is a few PHCs have disappeared. Where it has disappeared, I don't know. There is no subsequent increase in CHCs. So it is either a falsely claimed PHCs. On the contrary, Bihar and UP PHCs are increased to more than 200, 195 PHCs. You create PHCs without any functionality. 31% of the existing PHCs do not have electric supply or running water supply. Such places, why you build up new things? Make the functionality a reality. Make availability of human resource there a reality. Then you invest in construction. You concentrate. Otherwise, it is a wrong expenditure, and that should not happen. With these thoughts, I conclude, and these are the lady drummers, which is again a part of social justice and women empowerment, which used to be the men's role. Now the full-fledged drummers of women in Kerala, they are trying to impress the government of India team. So health system, public health system with a lot of community involvement and ownership, with full-fledged comprehensive healthcare of both curative and non-curative and health promotion activities with participatory planning, that is going to salvage Indian public health system. I stop here.
Thank you, sir, for this wonderful talk and very comprehensive insight on public health system. We have few questions here, sir.
Yeah, please.
One One which I think both Dr. Shailaja ma'am and I also thought of is, now we know public health brand cannot be born only by government sector. But since PPP is not working very well, should that be totally discouraged, or how can we better PPP model?
Public-private, what is a business? A business is when you provide service, you generate some profit out of it. And all those who are involved in that business, the shareholders, get a profit which is equally or maybe proportionate to the money invested. PPP, I'm not against a PPP in a partnership. I'm not against partnership, but it has to be a real PPP. Public and private should have benefits equally. I got so many examples where PPP, we both operate, but I take the profit and you collaborate. So there is to be a community participation. I operate, you cooperate, and that is what you call participation. That's not participation. We share the benefit equally. Chiranjeevi scheme in Gujarat, it was a PPP model of availing all cesarean section and any other complicated deliveries to deliver the best of quality technical intervention, and so that women's life is saved. But this PPP model worked very well in Surat, Ahmedabad, Baroda, and no PPP model of Chiranjeevi in the entire run of Kutch and in the border of Pakistan and the areas. Nobody goes there. Which private party won? So when the PPP model worked so well in Gujarat in under Chiranjeevi scheme, our friend Health Secretary Amarjit Singh, he operated it. He got everybody clapped his hands for this is working wonder. But what happened is, and the clients of district hospitals in these Gujarat, well-off part of Gujarat, all went migrated to these private hospitals. They got that. Okay, they got a good service. But why you don't strengthen and provide that quality service in these public hospitals? You need PPP where there is a same thing happened in Uttarakhand. I went on a CRM mission. I went to where is that? Where is that? Where the Snan and all take place? That district, Rishikesh district. I found district PPP model in district. I found when the PPP model came, that private sector wanted only X-ray machine, and there is no radiologist. One technician is there. There is no surgeon, not appointed by the same PPP model agency. But they ran the ultrasound and because there's huge money profit there. They did not want to do. They canceled many of the immunization sessions. Very reluctantly conducted immunization or tubectomy or all these things. So some benefit like that. So PPP model, private involvement should be very carefully calibrated. Clarity should be there. How much, who benefits what, and it should be strictly monitored. Otherwise, the private sector take you for a ride. They use the district hospital facility for everything they want and where their interest is. That should not happen. Thank you.
Thank you, sir. Sir, we have 4 basic principles of public health system. Along with that, what is the role of legal system to ensure efficient public health care or universal health care?
See, health is a human right. When it is denied, they should be forced to go to legal system. And judicial activism is good and saving at times, and some of the PLs are. But a responsible public health system should not create such opportunity. It should be minimized. We should be sensitive to the needs of the people, and when the noises are made and not listened to, then only they are forced to go to a PAL and thing. So why do you create such a situation? We should be much more proactive, and then only, I mean, as a doctor, a physician, under the Hippocratic Oath, whatever the people's feelings are, also our doctor's feelings should be. Why we clinicians don't have? We do the ward rounds. We don't check whether there is that lady has got the water in there to wash her hands, or there is no bed sheets to cover the newborn baby. And only when the Government of India officials come, all the brand new stock of towels and linens are out. Otherwise, it is. So this should not happen.
Any postgraduates, any faculty have any questions?
If I am scandalized any of the enthusiastic postgraduates, my apologies. But when you go to many PhD, many parts of the country, this is what we see, and then you get frustrated. And who is responsible? Who is so that we can't depend upon an energetic IAS officer coming to save the situation in 2 quarters and things like that. He is a short-term hero, but that should not be. The system should be driven by the medical professionals who are serving the thing. You know, I've been into UK, some of the ward rounds. A ward in charge, matron sister, she will make even a senior most consultant, fear and he'll have tremors if he is 10 minutes late or he is thing. Why did you do that? She commands like a mother-in-law. I mean, so that much of, because it is ingrained in that system that they're all responsible, even consultants. And no consultant, no professor in UK I've seen will ever say, I know everything. I am the HOD, I am the professor, nobody. If you ask a young postgraduate, ask a question, frankly, Mr. Antonia, I have no clue about it. Why don't you educate me? I want to know. This is the level of humility they express. I had a postgraduate examiner, and I have only seen his thick textbook of pediatrics, John Fafa. And to my utter surprise, he was the chief examiner for me in Department of Tropical Pediatrics. And there was an X-ray on lead poisoning, which is a standard tool, Viva questions, and a lot of bones, like anatomy Viva, a lot of bones, X-rays. So I saw it, maybe a UK physician may not recognize it. I saw the lead poisoning sign on the wrist X-ray, and I said, is it common in India? I said, definitely it is. And then I talked about the child labor in garages and closed without any window, the scooter garages and the workshops and the children, and then the inhaling lead fumes and battery fumes. And then he was asking, oh, how? That's why. I mean, they want to learn. No professor in UK ever say that I know everything. And they absolutely, there is nothing called shame. I don't know. They're honest. They're not a Hippocratic. I ought to know. So how can I reveal my ignorance in front of my PG? No. They will take that new PG to go and look up in the night itself before he goes to sleep, even in the midnight in the library, and come back 8 o'clock rounds with an answer. That's the way they teach.
Sir, thank you, sir. Really wonderful to hear your experience of so many years from different states. And it's a very rich experience, which we can't get in one session. You have seen the worst of the worst in public health system, and you still do that and actively advocate for that in every opportunity you get. And thank you for agreeing to our session, and really thankful for your time, sir. Hope we will have another opportunity with you again sometime. Thank you, sir.
I enjoyed this opportunity, and the more I talk, I feel a few people will listen, and I mean, it will be impressed upon their mind. So I am really indebted to BLDE and department, and including all the VIPs, Vice Chancellor and Dean. I hope it made some sense. It is 1 hour 15 minutes. I want to restrict to 1 hour, and but it went on because I'm a non-stop talker, so it goes on. But if you can, some of you can imbibe some reflections, some stories, I say, I will be more than you. I was in a national, I'll just take 1 more minute. In Jaipur, there was a national review on immunization, and so many health secretary all over there. And the sessions, Government of India, immunization experts, assistant commissioners were all there. And at the lunch break, one lady came and told me about that. Sir, do you remember me? So I said, I'm not, I'm sorry, who are you? Remember you used to come to Kionjar? Yes, I used to come to Kionjar. There was a malaria chemoprophylaxis with chloroquine for pregnant women. Used to come with care people. Yes, yes. Then she said about your story about 90% and 10%. Then I remember, oh, that story in many places. Sir, that impressed me so much. For hundreds of training sessions I've been using. And she is a CARE international staff lady. And she said, I've been doing so much. I was so thrilled. 22 years later, she is still recalling that thing. And that is a story I want to conclude now is, see, in any training, there are 50% who are just listeners. It doesn't make a difference because they are sent by CMO or any training. And there are about 20% who are very interested and active. But no, there is hardly 10% are very active and active. And 10% is such a negative thing, nothing is going to happen. They are interested in how many sweets you serve for lunch after the sumptuous lunch, whether it is ice cream also is served or not, and how much is the per day. That is, whereas this, and I used to appeal to them because there are 50% of fence sitters, they're just passive listeners. 10% those who don't believe in anything, you can't convert them, ignore them. But your 10%, and you with your 50% with fence sitters, and another, so 50 plus 10, 60%. Still there is about 20% with your effort, you can convert them and buying them. The 50% are just listeners, they will be always passive. That 20%, if you can get on your side, you can do wonders in any PHC, in any district, wherever you can. So I hope you are that 10% and you remember that story and try to, don't be bothered or discouraged by the 10% which are very critical in this own workout. Every training, every meeting, there is a mood spoiler. Ignore them. Let them have their say. Give them a chance to speak. Just ignore it. But get another person to speak what is possible. Then the rest of the people, at a later occasion, you can convert them and bring them to your side. Then things change. Thank you.
Thank you, sir. I, on behalf of Department of Community Medicine, BLD University, wholeheartedly thank you for this wonderful lecture and presenting us with nuances of public health systems, sir. As a token of our gratitude, we have a small e-certificate, which of course will be mailing it to you later. I'll just present it here, sir.
Yeah.
Yes.
Thank you. Thank you very much.
Gratitude for towards
Yeah.
you, sir. Thank you so much.
Well, Professor Yadunar is there. I mean, I just want to use on the screen. Okay. Thank you, sir. Thank you, Shailaja. So goodbye. Have a good day.